Thank you, Dr. Weiss. Good afternoon, everybody. My name is Joshua Hare. I'm the Louis Lemberg Professor of Medicine. It's my great pleasure to introduce the 30th Annual Miriam Lemberg Lectureship. The Lemberg name has been associated with the Department of Medicine here at the University of Miami for 30 plus years now, longer due to Dr. Lemberg's contributions as a cardiologist. As is traditional, I like to tell the story of how these two, the chair and the lectureship, came about. Around the same time, more than 30 years ago now, Miriam Lemberg, who was Lou's wife, was developing the chair in honor of Lou, while at the same time Lou was developing this endowed lecture for Miriam, both presumably without each other's knowledge. Now, 30 years later, we're very fortunate to have this lectureship, which is now in its 30th year, as I've mentioned, where we are able to bring in thought leaders and the greatest minds in cardiology from around the world. So many thanks to the Lemberg family, as represented by the Saltzmans. Paula Saltzman was Lou and Miriam's daughter. I believe she's here joining us on the call. And our great thanks to the family for the opportunity to have this lectureship. Thank you.
All, good afternoon and happy Wednesday. It gives me great pleasure to introduce Dr. Heidecker today for our internal medicine grand rounds. Dr. Heidecker graduated from the Innsbruck Medical School in Austria in 2006 and started her postdoctorate training at the Johns Hopkins University in Baltimore, Maryland. There, she was one of the first investigators to specialize in artificial intelligence in the field of cardiovascular medicine. Early on in her career, her aim was to improve patient care by finding a personalized care approach. When her mentor, Dr. Joshua Weiss, was recruited to the University of Miami, she followed him and continued her research in the field, focused on heart failure and cardiomyopathy. After 3 years of postdoctorate training, she joined the residency training program in internal medicine here at the University of Miami and Jackson Memorial Hospital. After her graduation from our residency training, she pursued a clinical fellowship in cardiovascular diseases at the University of California, San Francisco, which she successfully completed in 2015. Following her clinical training, Dr. Heidecker returned to Europe as a cardiologist at the University Hospital Zurich. She established a clinic for myocarditis, a highly productive research team, and a biobank for myocarditis. For this work, she received numerous competitive research grants. Throughout her training, she continued her research in the field of cardiomyopathies and published in prestigious medical journals, including JAMA, New England Journal of Medicine, Circulation, and the European Heart Journal. Since the COVID-19 pandemic, she investigates genetic factors that influence immune response to viral diseases. On her mission, she has support from a very large research team of investigators, fellows, and students. And she is the principal investigator on several research projects. Without further ado, I'd like to turn it over to Dr. Heidecker.
Thank you so much for the kind introduction. It's a great honor and pleasure to present here today. I think very fondly of my time at the University of Miami, and I have to say you're all lucky to be here. It's a really excellent training program. I know it's a hard work, but it pays off. So this is my talk about myocarditis and the COVID-19 pandemic. So these are my disclosures. A brief overview of my talk. First, I will talk about some background on myocarditis in general, because as you will see, COVID-19 myocarditis and myocarditis after the vaccine against against SARS-CoV-2 behaves very similarly, and the treatment is very similar. Of course, our evidence for the treatment and diagnostic approach is still limited because this is a very new situation we are all in, but I've done my best to give you an overview of the current literature and evidence that's out there. I will talk about the diagnosis of myocarditis, about COVID-19 myocarditis and potential genetic predisposing factors, and about vaccine-related myocarditis. And at the end, I will mention some possible future diagnostic tools for myocarditis and what we have been doing in our research team. So first, some background. Here you see an overview of viruses that were associated with myocarditis over the course of time. In particular, Coxsackie virus has been a very aggressive virus causing myocarditis. Later on, it was primarily parvovirus B19 that has been detected in biopsies of patients with myocarditis. Currently, there's a lot of research about parvovirus B19 in terms of when is it actually causative and when is it only a bystander that you find by coincidence in the biopsy. There's research that shows that replication numbers play a role. If there is active infection, then it's causative. But if there's low replication numbers, it may just be a bystander. So parvovirus B19 can be found also in healthy tissue. So that's why there's still research in the area to figure this out in a more specific way. But high replication numbers is a sign for active infection and a potential cause for myocarditis. And then now lately, of course, SARS-CoV-2 plays an important role in myocarditis. We asked ourselves the question, in particular in giant cell myocarditis, if there are any new viruses that haven't been described yet that may cause the disease. The reason is that in prior textbooks, there was discussion that it may be a purely autoimmune disease, or there could be a viral trigger, because you see that confluence of cells, like you see it, for example, also in herpes virus. So there was a potential hypothesis that it could be viral in nature. So we use the technology where we can screen for all known viruses and also their potential variants. And we looked at tissue from patients with giant cell myocarditis, but couldn't identify any virus. So it appears that at least at the stage when they have giant cell myocarditis, a virus is not the trigger anymore in the heart tissue. So it's purely autoimmune at that stage, at least. And that explains why they respond so well to immunosuppression, or the most to immunosuppression. Also in myocarditis in general, we looked at samples, plasma samples from those patients and also PBMCs. And also in those patients, we really didn't detect any relevant viruses, only those that are typically described to persist in the body, like herpes viruses, but no new viruses that haven't been described. So this supports the hypothesis that by the time myocarditis, the symptomatic breaks out, the virus has already been cleared from the system, but what is still there is a immune reaction that's self-maintaining, that sometimes we have to interrupt with immunosuppression. And similar findings have been shown with SARS, as you will see later in the talk. What was special about this technology was that while it was a high throughput analysis, it had a sensitivity and specificity similar to PCR through additional mapping of those sequences. So now to the diagnosis of myocarditis. The problem with myocarditis is that it presents very similar, like acute coronary syndrome. Patients come in with severe chest pain. Some patients describe a gripping chest pain. So in heart attack, we often hear the elephant sitting on the chest. Patients with myocarditis sometimes describe it more like somebody has their heart in a hand and then it squeezes the heart from outside. That's what some patients described. But of course, those descriptions are not sufficient for us to make the diagnosis. So if they come in with severe chest pain, we always have to rule out heart attack first, because that's, of course, the more life-threatening condition. And once that is excluded, then we move on with our other diagnosis. Patients also present with dyspnea. We've shown in one publication that women tend to have more dyspnea rather than chest pain. Well, men typically have chest pain. Fatigue, malaise often comes as a presenting symptom. Palpitations, syncope. Syncope is also a red flag that it may have a more severe course, because syncope may result from severe arrhythmias, from VTs. We had a patient who presented with syncope and actually turned out to have VTs later on. So that's always something that you should take very seriously and have the patient on telemetry for some days. Signs of heart failure, of course, and typically this occurs after 1 to 3 weeks after viral infection. So this is the classic course, and that's why I mentioned by the time we see the patient with chest pain and myocarditis, the viral infection has already healed, but the patient still has the inflammation in the myocardium. So the routine diagnostic workup always includes troponins. Also, we've shown that myoglobin in acute myocarditis is very indicative for the extent of LGE, but that's still research area that hasn't been as fully established as a marker in routine diagnostic. In routine diagnostic, we use troponin. In addition, we evaluate for the etiology, so we do a complete blood count. It's very important to also do the differential to see if the eosinophils are elevated, because that changes entirely the prognosis. If a patient has eosinophilic myocarditis, is a very aggressive form, and I will show later how elevated eosinophils will change your management. Then TSH, because autoimmune diseases that involve the thyroid often also present with myocarditis because there's systemic involvement of this autoimmune disease. We screen for autoimmune diseases with ANA and ANCA for vasculitis. And if we have a suspicion for sarcoidosis, which is also a form of heart inflammation, then we do soluble interleukin-2 receptor. On EKG, you may have ST changes also like in acute coronary syndrome, which makes it hard to differentiate the two. The ST changes may actually occur in a coronary distribution. And this is some hypothesis for this is that there are viruses that affect in particular the endothelial cells like parvovirus, and that may cause endothelial dysfunction and coronary spasm. And then as a result, the ST changes in the coronary distribution. And of course, patients may have arrhythmias, even AV block, if it's one of the more aggressive forms of myocarditis. On echocardiography, we may see the wall motion abnormalities, again, due to coronary vasospasm, for example. There may be wall motion abnormalities, but also due to effect of if the conduction system is affected, or if the tissue is just non-functional because of the extent of the inflammation. There may be pericardial effusion if you have myopericarditis, and decreased ventricular function and valvular regurgitation as a result. This is what I mentioned about our research we have done. We looked at how cardiac markers correlate with extent of late gadolinium enhancement on cardiac MRI, because cardiac MRI is one of the standard diagnostic techniques, and wanted to see how well can we correlate blood markers with the extent, so that blood may be a less expensive way of following patients and seeing their extent. Actually, myoglobin in the acute setting of myocarditis correlated very well with the extent of late gadolinium enhancement, more than troponin and other markers. And this is, again, still research area. We also checked in blood that was already collected from Coxsackie myocarditis mice, if this finding of myoglobin being elevated in acute myocarditis and as a marker is reproducible in those samples, because of course, one thing you may criticize is that our patients were diagnosed with MRI. So how do you know for sure it's myocarditis? So in definitive myocarditis in mice, a similar finding was found that myoglobin is actually more specific. Troponin, of course, is more sensitive because especially high sensitivity troponin is often elevated, but it doesn't correlate as well with late gadolinium enhancement. Again, this is research. This is not what we do in routine practice. This is a 12-lead EKG of a patient with myocarditis. So you see very classic in 2, 3, and AVF. You see ST elevations, as mentioned, the coronary artery distribution in myocarditis. So this patient, of course, we rule out acute coronary syndrome, but if that's not the case, then we rule out myocarditis. So what are indications for endomyocardial biopsy? You see here the typical case of lymphocytic myocarditis, and here eosinophilic myocarditis. And as I mentioned, eosinophilic myocarditis has a much more severe prognosis. So that's why it's important, if you have a suspicion that this could be the case, you do the biopsy. So cardiogenic shock or acute heart failure are clear indications to do a biopsy. Why is this? Because it changes management. So there are types of myocarditis that are very aggressive and have a poor prognosis if they are not treated with immunosuppression. One of them is eosinophilic myocarditis. Then there's also giant cell myocarditis. And sarcoidosis is less acute, but those are the ones that we want to exclude. And in those cases, we need to know the definitive tissue diagnosis to initiate immunosuppression early. And those are exactly the indications for endomyocardial biopsy when we suspect them: cardiogenic shock or acute heart failure, ventricular arrhythmias or high-degree AV block. So that often is seen in sarcoidosis also. Myocarditis or chronic inflammatory cardiomyopathy in the context of peripheral eosinophilia. That's what I mentioned earlier in the talk. Then if you suspect acute or dilated cardiomyopathy, that's suspected where you suspect a chronic inflammatory cardiomyopathy with continuous recurrent release of necrosis markers, particularly when autoimmune condition is likely or ventricular arrhythmias or AV block 2 or 3 is present. So that means when you have a patient and he's not recovering from his heart failure and he continues to have elevated troponin levels, then you should consider doing a biopsy to figure out what's happening. Or when you have ventricular arrhythmias or AV block 2 or 3, because that may be some type of infiltrative disease like sarcoidosis, which affects primarily the septum where the conduction system is located. Also, ventricular arrhythmias are typical for sarcoidosis because the granulomas that form in sarcoidosis create the substrate for reentry tachycardia. And ventricular arrhythmias are also typical in giant cell myocarditis. And a rather novel type of myocarditis, the immune checkpoint inhibitor associated myocarditis. So if there is a patient who gets immune checkpoint inhibitors and there's a suspicion for myocarditis, you should also consider biopsy, because in those patients, early treatment with immunosuppression and stopping the immune checkpoint inhibitors is very relevant for prognosis. So there, even 24 to 72 hours make a big difference on prognosis. There are some great publications on it with Kaplan-Meier curves where you see a drastic decrease in prognosis if you don't immediately treat them. So CMR, cardiac magnetic resonance imaging, is also important for diagnosis. That's basically what we use in all patients who don't meet the indications for biopsy. We've done a study where we looked on the value of CMR for risk assessment in myocarditis, and we also wanted to see how well markers reflect myocarditis after 3 months, so for the longer follow-up. And we found actually that patients at 3 months follow-up with cardiac magnetic resonance imaging, even patients where activity was still present, inflammatory activity, the troponins and CRP had already partially normalized or normalized. So this is not a good indicator in the long term. If you have a patient where you suspect a higher risk for chronic myocarditis, we advise to do a CMR. And CMR is an important risk predictor. So we saw that patients with increase in late gadolinium enhancement over the course of time have a much greater risk for cardiovascular complications. This is a patient where we had a relevant increase in late gadolinium enhancement, and this patient had to be resuscitated for VT. There's also larger studies by Greni and colleagues who have shown that especially late gadolinium enhancement in the septum mid-ventricular level is a risk predictor for adverse outcomes. So now moving on to COVID-19 myocarditis, how frequent is it? Autopsy studies are always a good way to assess the actual frequency or prevalence, because they, of course, you have a tissue diagnosis, you have sufficient tissue to be sure about it. This was a publication that did a summary of PubMed and Embase reporting of post-mortem cardiac pathology in adults who had COVID-19. There were 41 studies, including 316 cases. And the deceased were mostly male, 62%, and elderly, median age 75. And in those patients, myocarditis was found in 1.5%. The pathophysiology of COVID-19 myocarditis is that it's mostly macrophage dominant infiltration. So you see CD68 positive cells in about 86% of cases. It's similar to SARS-CoV, so the first SARS-CoV-1 virus. And lymphocytic myocarditis can also be found in 14% of cases. You see an upregulation of MAPK associated pathways and the complement system. And SARS-CoV-2 variants have been found in endothelial cells, cardiomyocytes, and macrophages. There have been electron microscopy studies, mostly in the early viremic phase of the infection, but the direct cardiotoxicity has not been really proven yet. So it may be that it's, again, this systemic inflammation that causes the damage of the myocardium. Has not been clearly shown that it's directly cardiotoxic, but the viruses have been found in different compartments of the heart. This is how the histology looks like of patients with COVID-19 myocarditis. Here you see the CD68 positive macrophage staining. So you see it's mostly macrophages that infiltrate the myocardium and less CD3 positive T cells. This is a case report, and I just want to emphasize here also how important case reports are. I feel like sometimes they are undervalued. This was a case report of a 37-year-old man with COVID-19 myocarditis, has been by now cited more than 700 times. And it's really important that we gain this knowledge through case reports. The fact that we know about COVID-19 vaccine myocarditis is also due to case reports that have been started, making us aware that there may be this association. So I encourage everyone to write case reports if you see interesting cases. So this 37-year-old man had severe myocarditis. You see enlarged cardiac silhouette, very widely enlarged, severe pulmonary edema. He had chest pain, dyspnea, and diarrhea, blood pressure 80/50, so hemodynamically becoming unstable. Laboratory values, troponin was massively elevated, more than 10,000. CKMB was 112, and also the natriuretic peptide was massively elevated, 21,000. On echocardiography, he had an enlarged heart with an LVEDD of 58. The ejection fraction was 27%, and so severely decreased, and he had trace pericardial effusion. This was his EKG, was not there in a better image quality, but you can see the relevant findings, ST elevation in 3 and AVF. So this patient was treated for COVID-19 myocarditis with cardiogenic shock. He received high-dose methylprednisolone for 4 days, immunoglobulins, norepinephrine, diuretics, milrinone, and antibiotics. And after 1 week of therapy, the patient dramatically improved. So you see here again the X-ray from the beginning, and then after 1 week of therapy, on echocardiogram, after 1 week, the EF normalized, troponin decreased to 220, and after 3 weeks, cardiac markers normalized. This is a consensus statement that just recently came out, and I think that's going to be valuable for everyone. ACC expert consensus decision pathway on the cardiovascular sequelae of COVID-19, and also speaks about what to do with COVID-19 myocarditis or suspected myocarditis. So this algorithm is provided where you have SARS-CoV-2 infection. If there's a low suspicion for cardiac involvement, no additional cardiac testing is recommended at the beginning. I think it's always useful to follow those patients to see how they progress, make sure they recover. But if there's increased suspicion for cardiac involvement, an EKG should be obtained, troponin, and an echocardiogram. And if there are concerning EKG abnormalities, elevated troponin, or wall motion abnormalities on echo, there should be a cardiology consultation. And then, of course, again, like in general myocarditis, we have to rule out the most life-threatening conditions, in particular acute coronary syndrome. So it really follows a similar algorithm as we do for myocarditis in general. We rule out acute coronary syndrome, and then if we have suspicion, any pulmonary diseases, pulmonary embolism, and any other septic shock, of course. Then, if the patient is clinically stable, we should do an MRI like we do for general myocarditis. And then depending on what the MRI shows, if there's mild to moderate myocarditis, we should consider hospitalization. And if there is pericardial involvement, we would treat this with NSAIDs and colchicine like we do for pericarditis in general also. If the ejection fraction is reduced, we do heart failure therapy. And then afterwards, like for general myocarditis, we recommend not to do strong, vigorous physical activities for 3 to 6 months. What we do in our practice is after 3 to 6 months, we do an exercise stress test and also a 24-hour EKG and an echocardiogram. If everything is normal, the patient can resume sport activities. If this is a patient who is unstable and high risk, then patient should be referred to an advanced heart failure center. As you saw, this patient case report that we just heard about, decompensated and was in very severe condition. So you should have those patients in a center where there is the option for mechanical circulatory support. Those patients should undergo cardiac catheterization, consider right heart cath, and an endomyocardial biopsy. And if the patient has lung injury also, they recommend steroids. Also for the mild to moderate myocarditis, they do that for lung injury. And if the ejection fraction is reduced, then initiate heart failure therapies, of course. And if there is an inflammatory state, if there's severe myocarditis, consider the use of steroids. And then again, once the patient has stabilized, no vigorous exercise for 3 to 6 months. And in those patients where the cardiac MRI is unremarkable, the patients can be followed as outpatients. If they have pericardial involvement, they get NSAIDs, colchicine, and close monitoring. So potential genetic predisposing factors for cardiac injury is something that our lab was interested in. March, when the pandemic broke out in 2020, we were wondering why some patients have this cytokine storm and some only have some very mild symptoms. And we thought that there may be some autoimmune component like you see in other autoimmune diseases. So we were very interested in the HLA system and looked specifically for that. We started an international collaboration with colleagues from Switzerland and Spain, and analyzed in this multi-center study 435 samples. We did full-length HLA class 1 and 2 sequencing with PacBio and also exome sequencing. And then we looked if of those HLAs that we tested for, it was 35 HLA alleles, if any of those correlates or is associated with intubation or ICU. And what we found was there was only one HLA C0401, that was clearly associated with intubation. It was not associated with ICU, and that may be because there are different thresholds in different countries when to admit a patient to the ICU. And I remember from Switzerland that the threshold was very low, for example, because there's just a lot of availability of ICU beds. But intubation has very clear criteria when to intubate. And for that, we found the clear association of HLA C0401 to be associated with intubation. And patients had a 2 times higher risk getting intubated when they had this HLA allele. Here you see the different data sets, 1, 2, and 3. In this data set, there were only very few patients who were intubated. So most likely the statistical power was not sufficient here to reproduce the results. But as you will see later on, we reproduced it in other data sets. What was also interesting is that this is a very plausible finding because HLA C0401 is among the top 10 alleles with the lowest binding capacity with SARS-CoV-2. So we think that those patients the antigen presenting cells may recognize, or the immune cells may recognize the virus later, and that may cause a somewhat delayed immune defense, but that of course is only speculation. The intubation, the relative risk for intubation with this allele was 1.5 overall, the odds ratio 3.5, and as mentioned, it was about amongst the top 10 alleles with lowest binding affinity. When this data was published on medRxiv, actually the same evening, somebody contacted us from Genotech that he reproduced our findings in 2,000 patients with COVID-19 and about 10,000 controls. So we included that data also in our analysis and then went on to look at GWAS data. We were, of course, surprised that in none of the GWAS studies this allele was found, but this can be explained by the statistical rules that are used in GWAS data, because you look at much more variables in GWAS data. Alleles with low effect size, as this one that we found, would not show up in the statistical analysis because you have such strict statistical rules that only alleles with very high effect size would show up. But when you look now specifically at HLA C0401 in GWAS data that has already been published, then you can actually reproduce our findings. So here we looked if HLA C0401 is associated with severity of COVID-19. And as you can see here, we had several thousand cases from this database and several 100,000 controls. And here in this meta-analysis, HLA C0401 was associated with COVID-19 severity. And then we also looked at susceptibility to COVID-19. And here, of course, we had even more cases. So these were more than 35,000 cases and even more controls, more than several million and more than 1 million. And you can see that that also in terms of susceptibility, HLA-C0401 seems to play a role. We then went on and wanted to see if there are any sex-specific differences when you look at acute cardiac injury. And actually, when we separated men and women, we saw that male patients who were carriers of HLA-C0401 had much higher troponin levels than those who were non-carriers. In females, there was no difference. And this is a trend that we see over and over with viral disease, myocarditis, cardiac injury. It seems that men have a higher risk. And why that is, why that may be, it may be, of course, a hormonal reason. There are animal experiments that support that, and I'll show some data on that also. So now moving on to vaccine-related myocarditis. When you look at the current literature, those are the most recent studies on vaccine-related myocarditis. There have been many published, but those are the most recent and the largest, and they correspond to what has been published previously also. So I just picked here the last 3 large population studies. This was a Danish study, which looked at individuals who were treated with Pfizer, Moderna, or Johnson & Johnson. They had more than 3 million in the population, and the cumulative incidence of myocarditis after the vaccine was 1.7 per 100,000. Interestingly, this was the only study that showed a somewhat higher incidence of myocarditis in women with the Pfizer vaccine, women 12 to 39 years old. In Moderna, it was overall the highest incidence in patients 12 to 39 years old, but for Pfizer, it was specifically for women, the higher incidence. May be genetic factors, because in all the other studies, it's usually men who have the higher risk. Overall, in this population study, 73% were men who had myocarditis. The next population study done by Kaiser Permanente had 50% individuals with Pfizer, vaccinated with Pfizer, 50% with Moderna. More than 2 million had 1 dose, and slightly less to 2.3 million, and slightly less had 2 doses. The higher risk was after the second dose. This is also something that you see in most studies. So it's usually men after the second dose, young men. Here the incidence was 0.58 in 100,000, and here was 100% men. Then the largest is a pharmacovigilance study from Moderna, where they had 151 million individuals. And here the incidence of myocarditis was 0.95 in 100,000. The highest incidence was again in male patients 18 to 24 years old after the second dose. So it's really, overall, you could say it's always approximately between 0.6 to 1.7 in 100,000. It's very rare. It's typically mild and self-limited, and it's in young men after the second dose primarily. It occurs typically within the first 2 weeks. There have been some reports that it may even occur after 1 month, although then it's of course difficult to establish any causality. The most patients we've seen developed symptoms within 2 days. This is an important study that brings the risk of vaccine-related myocarditis in perspective. This was a study done in Israel, a national study that looked at the risk of getting myocarditis from the vaccine versus getting myocarditis from COVID-19 infection. So this is a very important study. Each cohort had more than 800,000 individuals, and they were very well matched in terms of age, sex, risk factors, comorbidities, and prior exposure. And in this matched cohort, they saw that the relative risk for vaccine-related myocarditis is 3.2, while it is 18.3 after getting COVID-19. So a 6 times higher risk getting myocarditis from the infection itself compared to the vaccine. And here, for example, you see the risk of getting myocarditis from COVID-19 versus the vaccine. You see also the risk for pericarditis is higher with the infection itself. Also intracranial hemorrhage, interestingly, was much higher with the infection, and acute kidney injury and pulmonary embolism, or DVT in general, myocardial infarction. So you can see that there are strong benefits of the vaccine. The pathophysiology of vaccine-related myocarditis, there have been different mechanisms described, and it doesn't seem to be very homogeneous. It seems that patients react in different ways to the vaccine and develop myocarditis, probably because the immune system is so complex. It may be affected by prior vaccines they already had or infections. There may be maladaptive immune inflammatory responses, delayed hypersensitivity, molecular mimicry, and eosinophilic inflammation has been described. On biopsy, there are different types of infiltration, including macrophages, T cells, eosinophils, and B cells. So it's not as homogeneous as you see in the infection COVID-19 myocarditis. There has been reports that there's an absence of anti-SARS-CoV-2 spike protein antibodies, which makes molecular mimicry less likely. So there's still a lot of research needed to understand this better. There are more macrophages typically than T cells, similar to COVID-19, but it's not as homogeneous the finding as we see it in COVID-19. So here, the slide from before that I showed you, where you have a macrophage dominance in COVID-19, also in the vaccine, you see somewhat more macrophages, but there have been many reports that show the findings that I just presented. So here, work that we have done, we looked at data from 6,000 patients with myocarditis that have been seen in our clinic over the last 16 years. And we looked at the full age spectrum from children to adults to see what's the prevalence of myocarditis. And we see this, what is important here is that pre-puberty, that sex difference is not that remarkable yet. So you see male in blue and females in red. And you see that the big sex difference only starts at puberty, age 18 to 35. It persists at age 35 to 54. And then after menopause, it becomes more similar again, the prevalence. So this supports that most likely hormonal factors play an important role in myocarditis. And there seems to be a protective effect of sex hormones, which would explain why in COVID-19 we have less acute cardiac injury in women. With the vaccines, we have less myocarditis in women, and in general, myocarditis is less common in women. So there seems to be clearly a hormonal effect that plays an important role. This is a case of vaccine-related myocarditis that we've seen in our clinic. It was a 21-year-old man with no significant past medical history. He came with pleuritic chest pain, dyspnea, and 1 episode of fever of 38.2. The pain was alleviated by leaning forward, so typical pericarditis pain. Symptoms started in the evening after receiving the vaccine. So that's usually when we see them, same day or next day. Vital signs were stable. He was well compensated. Troponin was elevated at 391. NT-proBNP was elevated and CK. On EKG, he had sinus rhythm, heart rate 85, ST elevations in V4 to V6, and ST depressions in 2 and 3. So typical EKG changes. As required, we did the coronary angiography first, no obstructive coronary artery disease. And on MRI, he had the typical vaccine-related myocarditis findings. He had a normal EF, but then he had the subepicardial late enhancement in the inferior wall, and then also hypokinesis. We did an ibuprofen taper because we treated the pericarditis. The myocarditis was not severe. He didn't require immunosuppression. We just treated him for the pericarditis. And after 1 month's follow-up, he was already asymptomatic. And after 5 months follow-up, we did a CMR and there were no signs of myocarditis. So this is what I meant. Typically, those cases are self-limited. Troponin, CK, and NT-proBNP normalized. This is just another case of myocarditis after vaccine. This patient presented the next day, developed symptoms 1 day after the vaccine, had high troponins of 390, and also recovered very well without specific treatment. Here you see the late gadolinium enhancement, and he had a very good recovery without complication. So future diagnostic tools, just briefly. In 2007, we wrote about transcriptomic biomarkers as they could be used for diagnosis of myocarditis. At that time, there was already a test that could be used from peripheral blood. You could use the gene expression profile to detect transplant rejection. You may be familiar with this test. While this test, when we described it in our review article in 2007, was rather new, was already approved by the FDA in around 2009. And when I was a fellow at UCSF in 2012, we already used these findings of the AlloMap test to do biopsies. So I had a patient referred to me to do a biopsy because of the AlloMap results. So that was fascinating how quickly this field develops. We did a transcriptomic biomarker to detect myocarditis from endomyocardial biopsies, and it performed with very high accuracy. And actually the genes that were overexpressed in myocarditis involved the toll-like receptor signaling pathway and CD14, which was also biologically plausible. This was a study that we recently contributed to, where circulating microRNA was used to detect myocarditis. Methods were that microarray analysis for microRNAs was done on CD4 T cells and type 17 helper cells because they have an important role, as we know, in myocarditis. And they were measured, the microRNAs, in autoimmune myocarditis or myocardial infarction in mice. And also, in addition to autoimmune myocarditis in mice, there was a Coxsackie virus-induced mouse model. And after identifying microRNAs that are specific for myocarditis, the homologue for human, the human homologue was identified and tested in human samples to see if that's also specific for myocarditis in humans. These are the validation sets. First, it was tested in the primary cohort. You see here patients who are healthy, STEMI and non-STEMI, and you see that the microRNA in patients with myocarditis had distinctly elevated levels. Then this was validated in 3 cohorts. One was in myocarditis and myocardial infarction, highly elevated myocarditis in this group, in myocarditis. Then this was in our group with myocarditis and MINOCA. Also here, you see this microRNA is elevated. And in a third one with biopsy-proven myocarditis was again elevated. The accuracy was very high. The AUC in external validation ranged from 0.83 to 0.95. This is something that's very new that we are looking at, magnetocardiography, where we measure the electromagnetic vector of the heart to detect diseased myocardium. This is a new application for inflammatory cardiomyopathy. Just wanted to show briefly what we're doing here. We looked at non-ischemic cardiomyopathy, 118 samples, patients, and subjects without cardiomyopathy, 91. And what we saw was that there is an MKG vector, so a magnetocardiographic vector in the heart that can distinguish between diseased and healthy myocardium. And the specificity was high, the sensitivity not so, but in inflammatory cardiomyopathy, it works actually very well. And here you can see how this is illustrated. So in healthy individuals, the vector is very thin, and in the right upper quadrant, it's illustrated. And when patients have inflammatory cardiomyopathy, the vector gets wider, more diffuse, and moves in a different direction. And this is in vaccine myocarditis. And so we've seen that this can be used for quick screening. It only takes a few minutes to do this, and it's non-invasive, no side effects. It would be a good way for quick screening if there is an inflammatory cardiomyopathy. And what was even more exciting, we saw that with treatment, you can watch the vector improve towards normal. So this could be a way of monitoring early treatment response. So this was a patient, just within a few days, the vector became less wide and then moved towards the normal area. So normal would be up here. So in summary, standard diagnostic tests for myocarditis also apply for patients with COVID-19 or vaccine-related myocarditis. Myocarditis is rare in COVID-19 and even more rare after vaccination against COVID-19. Hormonal factors may contribute to the higher incidence of myocarditis in men, and the standard treatment of myocarditis and perimyocarditis is used for COVID-19 and vaccine-related myocarditis. So I would like to thank my team and collaborators that are working with me in Berlin and across internationally. And most importantly, I would like to thank Dr. Hare for being an amazing mentor. I think especially at the beginning of your career, a lot depends on luck, who you meet, who supports you. And he gave me my first position in research and has been an amazing mentor since then. And the University of Miami, who gave me the first opportunity to be trained in medicine. So that leap of faith that somebody gives you is very valuable and really determines where you go. So I'm very thankful for that, and encourage you, if you think of somebody who helped you like this at the beginning of your career, to check in with them and let them know how you're doing. I think, yeah, those are the key people who really help with your success. So thank you for your attention.
Thank you, Dr. Heidecker. That was a brilliant grand rounds. It was timely, informative, and really nicely presented. Thank you very much on very important topics that we're all seeing actively in clinic today. I wonder, I'm sure there's lots of questions, and I also would like to thank the Lemberg family as well. I understand there are individuals from the family in the audience, and we extend our appreciation for making educational programs like this possible. Perhaps I can begin with a question. You know, the timing, you made it very clear about the timing of the imaging studies, especially for checkpoint inhibitor-induced myocarditis. It's crucial to have it early. What about in the other forms? Cardiac MRIs are not always available on a stat routine basis, at least in our institution. And is there a window of opportunity that you really lose the ability to be proactive in treatment or diagnosis? How would you look at that as a cardiac consultant to a general medicine service?
Yeah, if it's acute, if it's conditions that need acute treatment, then I would go for the biopsy if CMR is not available, because it's really critical that you treat those patients within the first days. For eosinophilic myocarditis and giant cell myocarditis, that's the case. They're very acute. Sarcoidosis, they sometimes have already for many years, but especially in those two. And those, they make conduction defects, severe heart failure, severe arrhythmias. So there I would do the biopsy. And also in immune checkpoint inhibitor myocarditis, the prognosis really goes down if you don't treat within the first 24 to 72 hours. So it's very important to get to the diagnosis fast.
Thank you. Dr. Hare, would you like to make any final comments?
Bettina, thank you for a marvelous talk. Really an amazing overview on a very timely topic. I've one quick question. Patients who have myocarditis due to COVID or vaccination and have some degree of LV dysfunction, how long should they be treated with neurohormonal blockers for? Should they be treated? How long? And what are the recommendations there?
With COVID myocarditis?
Yes.
Yeah, so whenever somebody has a myocarditis due to a temporary trigger, there is the possibility to stop the heart failure medication after some time, and that should be a decision with the patient together, understanding the risk that heart function may worsen again. I personally would treat them for a year, as we do for other cardiomyopathies where we suspect a temporary trigger. For example, also with peripartum cardiomyopathy, you may consider after 1 year to reduce the medications. I think it's very important to follow them closely with echocardiogram. So if they do decrease in LV function, that you have the chance to reinitiate the treatment. But I would give them a year to stabilize. They have very low side effect profile. So yeah.
And any specific recommendations on what drugs should be used, since there's so many choices right now? For example, should we be using Entresto in these patients, or just standard ACE or ARB?
If it's we go by, if it's only mildly decreased, we usually do ACE inhibitors. If they're moderately severely decreased, we give Entresto, because it's, from our experience, faster acting. And yeah.
Okay, well, thank you very much. We very much appreciate it. Hope we get the opportunity to personally greet you here in Miami and welcome you back to your alma mater soon. And thank you again for everybody's participation. You'll see the MOC questions at the link in the chat. And I wish everybody a great and safe day. Thanks so much.
Thank you.